Again, thank you so much for the organizers. Thanks, Jens, for the kind invitation. I'll be talking about endoscopy. These are the objectives today that I want to go over. So I want to go over the different types of pathologies that can be treated with endoscopy. I want to introduce and widen the concept of the benefit zone. And I want to convey the choke points of why this is not more common in the US. The rationale, actually, Jens, comes from you. So this paper that you guys published, 1,500 patients, and you looked at the different, complications and the different types of complications, looked at a whole vast array of different comorbidities, and what was found is that surgical invasiveness delineated and predicted who will have complications. And so age above 65 and surgical invasiveness both predicted that there would be risk, that there would be complications in 5 out of 6 organ systems. And so, thank you, Jens. Non-MIS surgeons demonstrate the importance of minimizing the invasiveness of spinal procedures. We have worked a lot with the AO, and we forged this task force. And I think all of us in this room here right now, all of us are interested in technology-dependent techniques to reduce local operative tissue damage and systemic surgical stress. And that's what we have heard the whole day long. So how can we be more gentle to our patients, fewer complications, and achieve the same or better outcomes? That's a multicenter trial that's now, I think, 2 years old. So we looked at 500 procedures, all different type of pathologies, disc, central stenosis, foraminal stenosis, other pathologies such as synovial cysts. And we found this, that with this type of technology, we were able to keep our complication rates to a minimum, a total of 4.7%. So durotomy, epidural hematomas, complex regional pain syndromes that we saw in 2 patients, recurrent disc herniations. The new data comes now is like that we actually went a step further on the same basement and have now more than 7,000 patients where we did a prospective study including 1,261 full endoscopic spine surgeries prospectively collected. So there was only 1 patient that we had to exclude and compared it with a propensity matched also prospective cohort of 5,963 patients. Down there are some demographics, and you can see here operative levels. Everything is pretty well matched. As you can see, mainly we have cervical, we have thoracic, lumbar levels, which is most prominent, mainly 1 and 2 level surgeries. So propensity matched cohort, and we looked at the rate of infections in these patients. So more than 7,000 patients. And we looked at this. The rate of infections in full endoscopic surgery was 0.001. Traditional surgery is 1.1%, highly significant. But importantly, this technology, and this is going to be very difficult looking at real data now, to oversee that. So there's a 16 times reduced risk with endoscopic surgery compared to minimal or open surgery with these mainly non-instrumented surgeries. But that's a tremendous reduction, obviously, that is going to be high quality data, so it's going to be class 2 because it's prospectively collected data. And I think that's going to make a real difference, very similar to what you guys showing with the disc arthroplasty. I mean, at some point, we have to pay attention to the data. So 16 times reduction. Brings me to the next part. You guys are going to see that during the demonstration when Jens and I will be head-on, table to table. So here are the tools for the job. Again, every fellow at our program gets a T-shirt. I don't know what you guys get, but we get T-shirts. John doesn't know yet what T-shirts you're going to get, but I have a couple of... You like shaft bender? Okay, that's already given away, sorry. So here we talk about a working channel and endoscope. So here's the working channel, here's the irrigation channels, here's the illumination, everything that is yellow, here's the optics. Here, just side-by-side comparison. The most important thing is that with the microscope, you're 30 centimeters away. With the endoscope, you're 3 millimeters right at the target. Another very important distinction is that the endoscope, you can look around the corner. And so you can spare facet joints, and you don't need such a wide approach corridor. You can save the structures and be much less destructive. And again, have 16 times reduction of infections, for example. And that's the view. So we have 2 approach angles to the lumbar spine. It can be either interlaminar, which we all are familiar with, or it can be transforaminal, which is an approach corridor that we are not that familiar with. Everybody talks about it's a single-handed surgery, but everybody forgets about the poor stepchild, as always, because with the endoscopy, with the left hand, as you'll see in this demonstration, you also have to control a working channel, and the working channel has a bevel, and those bevels are very, very intricate, and each procedure has a different bevel, and so this bevel allows you not only to create a dead space, but also to retract neural elements, also to resect pathology. So, for example, you can use it as a chisel if you have an osteophyte. It's a very, very important part. Again, nobody talks about it, so now it gets its own slide. There's very powerful drills, and you'll see that in the lab. It's just then we use both the bipolar as well as a monopolar, the bovicautery. And the bovicautery we use mainly to detach yellow ligaments. So, for example, here's a laminectomy that we do. And you can actually go into the canal with the bovi because everything is in water, and with a low-frequency detached yellow ligament. And so that's very helpful and speeds up the procedure. And then everything is put together as a whole system. There's different providers. This is the system that we're going to use here. We have several different ones at the university. And then I want to just go quickly over the benefit zone, a couple cases which I think really make a difference. Here's a list of all the procedures that we defined with the AO spine, which can be done. 27 experts put together this paper where we have a nomenclature system that we propose so that we can standardize the literature and that people find the procedures and can publish using the same language. It's always an advantage. I will not talk about discectomies here right now because discectomies have been beaten to death. There's 3 randomized controlled trials. Each of them show that they're equal or better results with slightly fewer complications. So endoscopic 10%, traditional 13%. Everybody's going to be screaming, I don't have that many complications. I'm sure. And then medium complexity cases, which becomes a little bit more interesting. Again, Dr. Hartl, who was also involved in this. So here's this benefit area where we go up in the complexity and we get more and more benefits, but also there's an area where the curves cross, right? This is where we go crazy, right? When we start doing the crazy stuff that we like to show, right? At some point, that craziness, there is, again, and we're pushing the limits, and as long as you analyze it, I think that's totally fair, because this is not a static curve. Otherwise, we would be still in the Stone Ages. Here's one procedure that I very commonly do is a laminectomy, right? But endoscopically, it's a little bit more tricky. You have to be really very, very systematic, and we'll have talks on that. I'm not going to bore you guys with that. But here's a patient that I think exemplifies this, and again, we have more data on this. A 57-year-old male, morbidly obese, BMI of 60, so really very, very large patient, incredibly nice patient. Lower extremity pain, 10 out of 10. Importantly, also, had worsening of his bladder function when we saw him, and he had a 4-level lumbar spinal stenosis. You can see on the panels back there, not an easy patient to treat. And we did a 4-level laminectomy endoscopically. Again, a tour de force, not something that I would recommend. Certainly financially makes absolutely 0 sense. But, he did really well, and he's now, this was him 12 months out. He's actually now 3 years out, and I still am in contact with him, and he's doing well. The important stuff with this procedure, very much like the disc arthroplasty, right? Why should we destroy stuff that is still intact? So when you look at an endoscopic decompression, you see that the joints are nicely preserved. And that's what we want to accomplish, right? And so another thing that we have is, especially, with all that good food around currently, there's a lot of people that we treat that are morbidly obese. And we looked at that. What is the impact? How does it help us to take care of these patients? And interestingly, we found in 181 patients that we looked at that obesity had no effect on operative time, no effect on operative improvement, and no effect on intraoperative complications. So these patients still have increased induction time, prolonged hospital stay, medical complications, but all the surgical issues with large patients are partially remediated with that. And that's a huge deal. I mean, you have a BMI of 50, 60, again, they lose their bladder function. Being able to take care of them with an 8-millimeter incision doing a laminectomy, Next time you're into your elbows, you'll think about it. And the other thing is, if you look at the best data there is, endoscopic, at least in our hands, in the published literature, I'm not going to go through that because it's a short talk, is 9% total complication rates versus, from prospective randomized trial, 34% complication rates. I know what you're going to say. Nobody has that many complications, and that's great. But now let's come to the high complexity stuff, where I think really it's going to be difficult to argue and where we can really make a big impact. One of my favorite procedures, again, this comes into the cervical spine here right now, is this type of procedure, where a cervical endoscopic laminotomy in a patient like this, right? 84-year-old, lung cancer, sick as bones, and really the only thing he complains about is that he cannot type his email anymore. He's becoming myelopathic. Obviously, thank you so much. Yes, he has a bad deformity. Of course, yeah, because I mean his T1 slope is crazy, right? He's an old 84-year-old guy. He can stand, he can still drive his Porsche, which is important. And he brings flowers to my nurses. He's the best guy ever. I love this man. But he can't type emails anymore. And so that's really bothers him. And you can see that he's pinching off his cord here right now at C2, C3, C3, C4. But again, there's not a lot of options here that you can do. C2, C3, you probably wouldn't do a disc arthroplasty there, right? Exactly, because it would include the feeding tube at the same time. And I didn't see any integrated feeding tube products here yet. Maybe industry, listen up, that's maybe something for next year. So really not a good option there. A deformity surgery in an 84-year-old to try to correct this, also not the best option, right? Because everything he's bought, he's actually eating okay. There's no issues there. So this is a perfect case for, I think this makes a tremendous impact. So we just did a 2-level endoscopic decompression, and he's now a year out roughly. His hands is improved, his hand strength, and actually his Babinskis have normalized. So he's not myelopathic anymore. And we got an MRI afterwards. So these patients actually get a tremendous amount of decompression. So with the lumbar spine, you don't get a whole lot of decompression endoscopically. In the cervical spine, you get a lot of decompression. And the reason for that is the lamina, the ligament is just not as solid. So you get a tremendous amount of decompression. One more.
You go over the top for that?
Yeah, so you go over the top, yeah. So you get a really nice, you could theoretically do that with a tube too. There's no, this is exactly the same technique as we use with metrics tube. So, again, also a case that I thought fits very nicely in here. So 65-year-old male that I actually treated him, again, you see congenitally narrow canal. And for me, a patient with congenitally narrow canal, you see one level is highly stenotic. He has T2 signal changes. For me, those cases are always disc arthroplasty if I can, no matter what. Because, as we have seen, with your data so nicely, the level of adjacent level disease is going down with a disc arthroplasty. So if you put an ACDF in this patient, you can book him for the adjacent level right away. And so I think it makes a tremendous, tremendous difference there. So I did a disc arthroplasty 2017 on him, a 2-level Prestige LP. He's a farmer. He's the nicest, best patient you can imagine. I love this man. He's great. He's so much fun. Anyhow, so he was working on his farm for 4 years, and then he comes back like this. So 3 years later, he comes back, and this is his MI there. So he did well for 3 years. He was shoveling, throwing. He likes to throw these hay balls, and it always makes me a little nervous, but that's what he does. And now he got a big machine that he can, a forklift, so maybe that will help it. But we got an MRI here, and you can see that actually on top of this, he has developed T2 signal changes. Also, the upper level is not, it's actually decompressed. You don't see the spinal cord being displaced anymore. But it's still narrow, which was not unexpected. And then he had a right C8 radiculopathy from a foraminal stenosis, which you can see there on the sagittal one. And so what we did on him is we corrected all this with a cervical decompression in the back. We went in there, did a cervical lami, and the foraminotomy. And that actually has relieved his symptoms really well. This is something that you guys are going to see in the lab in a moment. And so here's his postoperative image, and then of course 6 months he's well, but however, the lumbar spine, he's now wants to have this fixed. Anybody artificial disc there? He's throwing hay balls, contact sport. Sometimes they fall down, so you have to ask Jens what that is.
Stenosis, no.
Yeah, so my plan is to do an MIST lift on him there. So the big elephant in the room, why is not everybody doing this? There's, at least in our hands, I think switching to a more minimal invasive practice, it increases the productivity. The patient outcome are definitely favorable, superior oral ergonomics, but then there's the learning curve and the capital. Here is a hospital stay, and this is what I see in my practice very quickly is, the time that you spend on inpatient care is just tremendously reduced. So discectomies typically go home. Now I know with metrics they go home typically too. Laminectomies, and that's where it becomes more prominent, right? Anybody below 70 goes home with these procedures versus 2.4 with tubes. And then with T-lifts, it even becomes more prominent. Again, I don't do a whole lot of endoscopic T-lifts. I think that's where the technology is right now. That's where we're going to see a lot of changes the next couple of years. I think that's where the technology is still, in infancy. But I think there's a lot of data that confirms that the results are at least equal. And learning curve, so there are, as you've seen on the list before, there's a lot of different procedures we do. Each of these procedures have their own tricks, as you've seen. It's not the same. Even the different disc arthrobiases we've seen, they all have their nuances, and the same is true with endoscopy. Now, we've been very fortunate with the AO Spine supporting this effort, with Espineo supporting this. We published a book on that. There's like all schedules and a lot of courses now moving people along. Capital investment is, there. It needs to be done. Now, interestingly, a lot of the Asian countries, they skip the microscope, very much like in Africa, they skip the landline, right? So we're kind of stuck in our old ways. It's like we have some old IP here in this country, right? We just can't let go. But anyhow, there's a song for that too. My daughter, I can sing that afterwards. And then last thing is, so one thing that we all agree upon is it's data, right? I mean, I think the really important thing for us to move the field forward is data. And I've been really disappointed by, registries and other ways to collect data. Retrospective, Neil is here, right? I mean, having 3 nurses going through patient charts and like they pick up some, I don't know what they pick up in their old food, that clutter and the other stuff in the patient charts, right? But the data is garbage, total garbage. Actually, we did a study where we looked at the opioids registry from state of Washington, and that database is worth not even the name. I mean, that's sort of like it's a negative value. I don't know who's putting any money into that. And so these registries really have very, very little, validity because there's so much missing. And so what we've been trying to do is right now, so we've tried to do this via a smartphone app because a lot of patients have this. And then so what we've done right now, so now we have the standardized procedures named with the AO Spine. So everybody talks the same language, which is important, right? Everybody, as we know. And then we have outcome monitoring. So for me as a surgeon, it's actually really nice because I see on post-op day how my patient is doing. Post-op day 2, I see if they're getting better, they're worse. If they don't get better, I might call them. So it's really nice to have that sort of functionality. Then there's the ability to chat, so I can actually send them a quick message, if there's an issue. And there's electronic post-operative follow-up. So these patients I don't see in follow-up anymore. Instead, they send me I get a message 2 weeks afterwards with a picture of the wound. And the standard question, right? Fever, night sweats, anything. In reality, we don't ask anything else anyhow. And the 3 months, the same thing. So if everything goes well, those 200 patients that I treat endoscopic a year don't come to the clinic twice, is 400 patients visit. By the way, you're not getting paid for that. And the patients actually like it because, parking is not free typically either. And so if everything goes well, I think it's really the best thing. And honestly, I enjoy to see how my patients are doing. I'm so much more connected with them now because, I see every day, and I check it once. Oh, Miss blah, blah, blah is not doing great. Let's give her a quick call. It's much easier than they calling your clinic. They don't get a hold of anybody. They call patient services. And suddenly you have 10 emails that are all pointless. And so that's what we've been doing. And so and the nice thing is also we see now really very clearly how patients do immediately after surgery. Now this is a very interlaminar, very simple case where there's good recovery, as you can see. And, this patient is doing well. So I think we're learning much more granular data, how our patients do, and also about this perioperative period, because we shove our patients out the hospital the first day and then have not a lot of idea. They all kind of put the doggy eyes on when they see you in clinic and they want to be nice. But how they really do, actually, they're pretty honest what they put into these outcome sheets there.
Is this a proprietary app or is that through AO?
We did it via the university, so it's a research project. So it's again, the nice thing about this is totally scalable. So and so we actually right now carrying out to University of Brown is starting, Michigan is starting. So we're trying to really sort of like, get some real data. And then also, the thing is, the sad truth is that often people that are at the podium are not the best surgeons. And so, we have to see what you're good at and what you can learn from other people. I've learned so much stuff from these courses where I see people that work in the periphery in a small hospital, and they have something that is really awesome, right? And so I hope that this is going to help us to learn from the ones that have really figured out some nice tricks, right? Like we do at these courses, right? I saw your trick with the osteotome. I love it, right? And I'm going to just absolutely do this. And so I think this is hopefully going to help us to learn from people who have figured out something really well so that we can all learn from each other and better help our patients. Conclude here. So I think the full endoscopic treatments have been standardized now. We have names for them. I think the outcomes are very favorable, and the most important thing is reduction of complication rates. Even more important, with this type of technology, the rate of infections is decreased 16-fold. It's not like percentages, it's 16-fold reduction, which blew us off. 7,000 patients, really a very powerful study, not published yet, but it's there. And I think future development are really going to advance this field. So again, I wanted to thank everyone for listening, and here are some thank yous. Thank you.